Welcome. This is the first session in the neuro-ophthalmology section, and in this session we are going to discuss the anatomy of the afferent visual pathway, its arterial supply and venous drainage. Starting with the optic nerve developmentally is a part of the central nervous system, and anatomically it extends from the optic nerve head to the optic chiasm. Each optic nerve has 1 to 1.2 million axons of retinal ganglion cells, and the optic nerve is divided into 4 parts: the intraocular part, also called the optic nerve head or the ONH, the intraorbital part within the muscle cone formed by the recti muscles, the intracanalicular part within the optic canal, and the intracranial part from the optic canal up to the optic chiasm. The intraocular portion of the optic nerve is the portion within the opening and at the level of the sclera. The anteroposterior length of the intraocular portion of the optic nerve is 1 mm, the vertical and the horizontal width being between 1.5 to 2 mm. The vertical width being larger than the horizontal width, the optic disc, that is the surface of the intraocular portion of the optic nerve, appears vertically oval on ophthalmoscopy. The optic cup is a funnel-shaped depression devoid of axons, through which pass the central retinal artery and vein. The center of the optic cup is slightly temporal to the center of the optic nerve. The intraocular portion of the optic nerve head is divided into 4 parts. Anteriorly there is the superficial nerve fiber layer continuous with the retinal nerve fiber layer, the prelaminar layer adjacent to the choroid, the laminar layer adjacent to the sclera of the eyeball, and the retrolaminar region behind the laminar region. The superficial nerve fiber layer has a retinotopic distribution of the ganglion cell axons approaching the optic nerve head. So this diagram represents an ophthalmoscopic view of the fundus, with the lines representing the direction of travel of the nerve fiber layer axons. In the papillomacular bundle, the nerve fibers travel straight to the temporal margin of the optic nerve head. But here it is important to understand, although it reaches the temporal margin of the optic nerve head, neuro-ophthalmologically speaking, it belongs to the nasal hemifield of the retina. And because of that, these papillomacular bundle, like the other nasal fibers, cross in the optic chiasm. Fibers from the retina temporal to the fovea travel in arcs above and below the papillomacular bundle to the superotemporal and the inferotemporal margins of the ONH, and the nasal fibers travel directly to the nasal margin of the ONH. This diagram represents a cut section of the eye, with this representing the posterior surface of the eyeball and this representing the optic nerve. So the peripheral fibers entered the peripheral portion of the optic nerve, and the central fibers cross the peripheral nerve fibers anteriorly on the retinal surface and then lie anterior to the peripheral nerve fibers within the retinal nerve fiber layer as they travel towards the optic nerve head, and enters the optic nerve head more centrally than the peripheral nerve fibers. The macular fibers occupy the central portion of the optic nerve head. In the prelaminar region, the nerve fibers are surrounded by astrocytes, which divide the nerve fibers into 400 to 600 fascicles, each of these fascicles containing about 2000 axons. The astrocytes are not restricted to the prelaminar region but are present throughout the intraocular and the intraorbital portion of the optic nerve. The astrocytes also form a membrane lining the inner surface of the ONH. A layer of astrocytes also surround the circumference of the nerve and is separated from the adjacent choroid by the border tissue. As a variation, the adjacent RPE and the choroid may fail to reach up to the ONH margin, or may be exposed at their termination near the ONH, resulting in varied peripapillary pigmentation patterns. The laminar region consists of connective tissue plates which are continuous with the sclera and are made up of collagen types 1 and type 3, elastin, laminin and fibronectin. The plates have ports 200 to 300 in number, which allow the nerve fascicles to pass through. The ports are wider in the superior portion of the ONH compared to the inferior portion of the ONH. The retrolaminar region is the region where the individual fascicles get a myelin sheath, and the myelin sheath is produced by oligodendrogliocytes surrounding the axons. The entire nerve gets surrounded by an optic nerve sheath, and the diameter of the nerve increases significantly from 1.5 mm to 2 mm in the superficial portion of the optic nerve head to 3 mm in the retrolaminar region. The posterior boundary of the retrolaminar region is not defined anatomically and is continuous with the intraorbital portion of the optic nerve. The intraorbital portion of the optic nerve is 25 to 30 mm long and is much longer than the distance from the globe to the optic canal, which is 18 mm only, and this redundancy in the length of the optic nerve allows for flexibility during sudden eye movements. As we have mentioned, the optic nerve sheath is present behind the laminar region, and it consists of an external layer continuous with dura, a middle layer continuous with arachnoid, a subarachnoid space which extends up to the lamina cribrosa, and inner layer continuous with the pia, which is highly vascular. So the subarachnoid space extends up to the lamina cribrosa, which is important to remember. The arachnoid and the pia send septi across the nerve, and a layer of astrocytes separate the nerve fibers from the septi, and the septi are present up to the optic chiasm. The septal system provides mechanical and nutritional support to nerve fiber. The intracanalicular portion of the optic nerve within the optic canal is 4 to 10 mm long, and the dural sheath of the optic nerve here is tightly adherent to the periosteum of the optic canal. Because of this strong adhesion, the intracanalicular portion of the optic nerve is prone to damage in severe head injuries, particularly blows to the eyebrow region, which results in shearing injury followed by interruption of the vascular supply to the optic nerve here. The ophthalmic artery lies inferior to the optic nerve within the optic canal, and the anterior opening of the optic canal is wider vertically, while the posterior opening is wider horizontally. The medial wall of the optic canal is thin and is prone to damage, particularly during transsphenoidal endoscopy. The intracranial portion of the optic nerve extends from the optic canal to the optic chiasm and has a variable length of 3 to 16 mm depending on the location of the optic chiasm. The ophthalmic artery lies inferior to the optic nerve. The internal carotid artery is inferolateral to the nerve or the chiasm. The anterior cerebral artery arising from the internal carotid artery passes medially over the optic nerve, and the falciform ligament and the gyrus rectus of the frontal lobe lie above the optic nerve. The falciform ligament is a fold of dura lying above the intracranial opening of the optic canal. Once the optic nerve becomes intracranial, the optic nerve loses its sheath. In the optic chiasm, there is a decussation of the nerve fibers, with the nasal retinal fibers, which constitute 53% of all retinal fibers, crossing over to the opposite side. And of these decussating fibers, the inferonasal extramacular fibers, after reaching the optic chiasm, run anteriorly briefly in the opposite optic nerve before resuming their posterior course in the opposite optic tract. And this forward bend in the opposite optic nerve is called the von Willebrand's knee. The supranasal extramacular fibers cross over to the opposite side in the posterior portion of the chiasm without bending forwards, and the nasal macular fibers cross over in the chiasm in the vertically central posterior part of the optic chiasm. The temporal macular and temporal extramacular retinal fibers pass uncrossed to the ipsilateral optic tract, and these temporal fibers constitute 47% of all the retinal nerve fibers, so there are more nasal fibers than temporal fibers. The optic chiasm lies in the antero-inferior wall of the third ventricle and anterior to the hypothalamus, about 10 mm above the pituitary gland. So here we have the optic chiasm lying in the floor of the third ventricle, anterior to the hypothalamus and superior to the pituitary gland. This configuration is present in 70% of individuals. In another 15% individuals, optic chiasm is located slightly anteriorly, in which case it is called a prefixed optic chiasm. And in the remaining 15%, the optic chiasm is located slightly more posteriorly, when it is called a post-fixed chiasm. The optic chiasm is covered by arachnoid pia layers, and the size of the chiasm is 8 mm anteroposteriorly, 12 mm in width and 4 mm in height, and it is inclined at almost 45 degrees angle to the horizontal. The optic chiasm is supplied anteriorly by the anterior cerebral artery and the anterior communicating artery, and posteriorly by the posterior cerebral artery, the posterior communicating artery and the basilar artery. So the optic chiasm is supplied both by the anterior and the posterior circulation, since it is located centrally within the arterial circle of Willis, which we will be discussing further when we discuss the arterial supply. The optic tract runs from the optic chiasm to the lateral geniculate nucleus. Each optic tract, as we have discussed, carries the temporal fibers from the ipsilateral eye and the nasal fibers from the contralateral eye, thus serving the contralateral visual field. So the left optic tract serves the right visual field and the right optic tract serves the left visual field. The fibers from the superior retina of both the eyes shift toward the medial portion, and those from the inferior retina shift towards the lateral portion of the optic tract, and those from the macula are located in the superolateral portion of the optic tract. The magnocellular axons, which we will come to shortly, lie peripherally, and parvocellular axons lie centrally within the optic tract, and the contralateral parvocellular axons lie above the ipsilateral ones. The lateral geniculate nucleus is a mushroom-shaped structure located in the posterior thalamus. Only 70% of all optic nerve fibers reach lateral geniculate nucleus, and most of the remaining 30% go to serve the pupillary light reflex, and the retinal ganglion cell supplying the pupillary light reflex are said to be intrinsically photosensitive retinal ganglion cells. At the lateral geniculate nucleus, the axons of the retinal ganglion cells synapse. So this is the first synapse of the visual pathway. The lateral geniculate nucleus contains 6 layers from below upwards. Layers 1, 4 and 6 receive crossed fibers from the contralateral optic nerve, and layers 2, 3 and 5 receive uncrossed fibers from the ipsilateral optic nerve. The axons of the cells of the lateral geniculate nucleus form the optic radiation, which runs from the lateral geniculate nucleus to the primary visual cortex. Layers 1 and 2 of the lateral geniculate nucleus receive input from the M cells. The M cells are the retinal ganglion cells with large receptive fields and larger axons. And axons from layers 1 and 2 of the lateral geniculate nucleus form the magnocellular pathway involved in the detection of motion. Layers 3, 4, 5 and 6 receive input from the P cells, the P cells being the retinal ganglion cells with small receptive fields and smaller axons. And axons from these layers of lateral geniculate nucleus form the parvocellular pathway, and the parvocellular pathway is involved in visual acuity and color vision. The central part of the lateral geniculate body or the lateral geniculate nucleus is called the hilum and contains the macular fibers and is supplied by the posterior choroidal artery, a branch of the posterior cerebral artery. The medial horn containing fibers from the superior retina and the lateral horn containing fibers from the inferior retina are supplied by the anterior choroidal artery, which is a branch of either the anterior cerebral artery or the middle cerebral artery. In addition to the lateral geniculate nucleus, the fibers of the optic nerve also project to 7 other primary nuclei. The lateral geniculate nucleus contains 70% of all the retinal nerve fibers, which via the optic radiation project to the primary visual cortex. The next major pathway is the light reflex pathway, wherein the retinal nerve fiber layers project to the pretectal nuclei. But in addition to that, other retinal fibers also project to the suprachiasmatic, supraoptic and the paraventricular nuclei in the hypothalamus, the suprachiasmatic controlling the circadian rhythm and the supraoptic and the paraventricular having an endocrine role. In the midbrain, apart from the pretectal nucleus, some other retinal fibers also project to the accessory optic system. which record speed and direction of movements of large parts of the visual system, and superior colliculus, which integrate stimuli from multiple sense organs and reorient the sense organs of the head towards object of interest, including the eye, by generating saccades, which we will be discussing in the session on supranuclear disorders of eye movement. Other retinal fibers pass to the pulvinar in the thalamus, which is associated with visual attention and blind sight. We will be discussing blind sight in the session on disorders of higher visual system. The optic radiation runs from the lateral geniculate nucleus to the primary visual cortex in the occipital lobe, and there is a superior bundle of the optic radiation and an inferior bundle of the optic radiation. The inferior bundle of the optic radiation run anteriorly in the temporal lobe and then turn laterally anterior to the temporal horn of the lateral ventricle, and then run posteriorly to the primary visual cortex in the occipital lobe. The superior bundle of the optic radiation run posteriorly in the parietal lobe and then reach the primary visual cortex in the occipital lobe. So the superior bundle of the optic radiation lies in the parietal lobe, and the inferior bundle of the optic radiation lies in the temporal lobe, and the turning of the inferior radiation is called the Mayer's loop. Within each bundle, the macular fibers run laterally and the peripheral fibers are located superiorly and inferiorly. The primary visual cortex is located on the medial and the posterior aspect of the occipital lobe. So this diagram shows the medial aspect of the left occipital lobe, and the primary visual cortex is located above and below the calcarine fissure. The fibers of the optic radiation terminate in layer 4 among the 6 layers of the visual cortex, and this primary visual cortex is also known as V1, striate cortex, or broadband area 17. The superior fibers of the optic radiation representing the inferior visual field terminate in the superior lip of the calcarine fissure, and the inferior fibers of the optic radiation representing the superior visual field terminate in the inferior lip of the calcarine fissure. What is very important to remember is that macular fibers terminate most posteriorly near the tip of the occipital lobe, and the fibers from the peripheral visual field are located more anteriorly in the primary visual cortex. Almost 60% of the visual cortex is dedicated to the central 10 degrees of the retina, and the most anterior part of the visual cortex receive only crossed nasal fibers from the contralateral eye and do not receive fibers from the ipsilateral eye, and thus the most anterior part of the primary visual cortex represents the extreme temporal field of the contralateral eye. In the primary visual cortex, there are 4 basic types of cell. The circularly symmetric cells respond to a small light source which is independent of motion or orientation. The simple cells respond to line or pattern, either light or dark, moving in a specific direction and in a specific orientation in the center of their receptive field, and the simple cells may be either on-center or off-center type. The complex cells respond to linear stimuli also, but anywhere in their receptive fields, and are less specific to the orientation of the stimuli. The complex cells may also be either on-center or off-center type. The hypercomplex cells respond to linear stimuli of a specific length, and these 4 types of cells explains why certain visual stimuli catch our attention over others. The neurons in the primary visual cortex are known to be arranged in 2 columns, the orientation columns and the ocular dominance column. The orientation columns lie perpendicular to the cortical surface and respond to linear stimuli at specific angles of orientation, and they are formed by groups of cells responding to linear stimuli with similar angles of orientation. The ocular dominance columns lie perpendicular to both the cortical surface as well as the orientation columns and respond preferentially to stimuli from either one eye or the other. So in one ocular dominance column, all the cells respond to stimuli from only one eye. Among the visual association areas, area V2 and V3 receive connections from area V1 and then project along 2 pathways. We have the dorsal occipitoparietal wear pathway and we have the ventral occipitotemporal what pathway. The dorsal occipitoparietal or the wear pathway is to area V5. also called the middle temporal area, and is located in the superior temporal sulcus and gyrus subangularis. And this area V5 provides the function of motion detection, including speed and direction, as well as visuospatial functions. The ventral occipitotemporal or the Watt pathway to area V4 is located in the lingual and fusiform gyri, provides the function of object identification and color vision, and so is called the Watt pathway. The arterial supply consists of an anterior circulation and a posterior circulation. The common carotid artery arises from the innominate artery on the right side and directly from the aortic arch on the left side, and then it divides into an external and an internal carotid artery at the level of the angle of the jaw. The internal carotid artery carries the major blood supply to the intracranial contents, and there is extensive collateral connection between external and internal carotid artery territories. The posterior circulation is provided by the vertebral arteries arising from the subclavian arteries and pass through the cervical vertebral foramina to reach the foramen magnum. The internal carotid artery of the anterior circulation enters the skull in the carotid canal within the petrous bone, where it lies close to the seventh cranial nerve as well as the middle and the inner ear. It then turns upward to become intracranial through the foramen lacerum. Then it turns forward to enter the cavernous sinus and runs parallel to the body of the sphenoid. Here it gives off two branches which supply the sellar and the parasellar areas. We have the meningohypophyseal branch and the inferolateral branch. Near the anterior cavernous sinus, the internal carotid artery turns upwards and backwards under the anterior clinoid and the optic nerve. Then it passes through two dural rings to become intradural. After becoming intradural, the internal carotid artery gives off the following branches. First is the ophthalmic artery, then there is the anterior choroidal artery supplying the optic chiasm, the optic tract and the lateral geniculate nucleus, and the posterior communicating artery, which anastomoses with the posterior cerebral artery, forming a part of the circle of Willis, thus joining the anterior circulation with the posterior circulation. It runs parallel and medial to the third cranial nerve, and aneurysms of the posterior communicating artery can interfere with the function of the third cranial nerve. The anterior cerebral artery crosses over the optic nerve and gives the anterior communicating artery, which is also a part of the circle of Willis, joining the two anterior cerebral arteries. The anterior cerebral artery then travels upward along the medial surface of the frontal lobe and supplies the premotor frontal cortex, which generates voluntary saccadic function. The internal carotid artery terminates as the middle cerebral artery, which travels along the lateral surface of the brain, usually between the parietal and the temporal lobes. Here it supplies the optic radiations in the parietal and temporal lobes and also supplies the occipital tip. And as we have mentioned, at the occipital tip, the macula is represented. So usually the macula is supplied by the anterior circulation, and the rest of the visual field is usually supplied by the posterior circulation. The middle cerebral artery also supplies the middle temporal area, which provide motion detection and smooth pursuit function, the Ware pathway. The ophthalmic artery originates from the top of the internal carotid artery siphon, where the internal carotid artery loops upwards and backwards under the anterior clinoid process, and the ophthalmic artery enters the orbit through the optic canal lying inferior to the optic nerve. The branches of the ophthalmic artery include the central retinal artery, which enters the optic nerve 10 to 12 mm posterior to the globe and supply the inner two-thirds of the retina. The lacrimal artery runs along the lacrimal nerve to supply the region around the lacrimal gland, the lateral portion of the upper and lower eyelids, and the lateral rectus muscle along with its anterior ciliary artery. So the lacrimal artery contributes to the blood supply of the anterior segment of the eye, and the lacrimal artery gives off the zygomaticotemporal and the zygomaticofacial branches, which exit the lateral orbital wall through their respective foramina through the temporal fossa and face respectively. The frontal branch of the ophthalmic artery runs along the frontal nerve, and the terminal branches of the frontal artery are the supraorbital and the supratrochlear. The superior muscular artery supplies the superior oblique and the superior rectus along with the anterior ciliary artery of the superior rectus. The inferior muscular artery supplies the inferior rectus and the medial rectus along with their anterior ciliary arteries. The anterior ethmoidal and the posterior ethmoidal branches of the ophthalmic artery enter the ethmoid sinus through their respective foramina in the medial orbital wall. The dorsal nasal branch of the ophthalmic artery and the superior and inferior medial palpebral branches of the ophthalmic artery supply the medial regions of the eyelids and the nose. The remaining branches of the ophthalmic artery, and more important so far as the eye is concerned, are the long posterior ciliary arteries and the short posterior ciliary arteries. The long posterior ciliary arteries enter the posterior sclera around the optic nerve and travel to the anterior segment, where it joins with the anterior ciliary arteries from the insertions of the recti muscles to form the greater arterial circle in the anterior portion of the ciliary body. Branches from the major or the greater arterial circle travel centrally within the iris and anastomose with each other to form the lesser arterial circle near the collarette of the iris. The short posterior ciliary arteries, around 20 in number, also enter the posterior sclera around the optic nerve and supply the choroid and the outer one-third of the retina. As we have already mentioned, the inner two-thirds of the retina is supplied by the central retinal artery. In 20 to 30% of individuals, the short posterior ciliary arteries also supply a portion of the inner retina near the macula, and this is called the ciliretinal supply, which becomes very important in protecting the macula in cases of central retinal arterial occlusion in patients who have the ciliretinal supply. Around 4 short posterior ciliary arteries anastomose in the sclera around the optic nerve head to form the arterial circle of Zinn-Holler. This arterial circle of Zinn-Holler is often incomplete and may be divided into an upper and a lower portion. The terminal branches of the short posterior ciliary arteries are end arterioles without anastomosis between the adjacent branches, and thus form watershed zones which are vulnerable to hypoperfusion. The intraocular portion of the optic nerve is supplied by the paraoptic branches of the SPCs and recurrent collaterals from the choroid and retina. The intraorbital portion of the optic nerve is supplied by SPCs supplying the most anterior portion, intraneural branches of central retinal artery supplying the anterior portion, and branches from the ophthalmic artery and its pial vascular network supplying the posterior portion. So the anterior-most portion is supplied by the short posterior ciliary arteries, the anterior portion supplied by the central retinal artery which lies within the nerve in this region, and the posterior portion of the intraorbital optic nerve receives blood supply from the ophthalmic artery. Coming to the posterior circulation, the vertebral arteries penetrate the dura at the foramen magnum and first gives off the posterior inferior cerebellar artery, which wraps around the brainstem and supplies the medial and lateral aspects of medulla and the inferior cerebellum. Then the two vertebral arteries join with each other to form the basilar artery, which ascends along the brainstem. The basilar artery gives off the anterior inferior cerebellar artery, which supplies the pontomedullary junction and the distal cerebellum. And in this location, we have the 7th and the 8th cranial nerve nuclei. Perforators from the basilar artery supply the median portion of the brainstem, and in this region we have the medial longitudinal fasciculus, the pontine paramedian reticular formation, and the nuclei of cranial nerves 3, 4 and 6. At the level of the midbrain, the basilar artery gives off the superior cerebellar artery, which may partially supply the 3rd and the 4th cranial nerves. Then the basilar artery finally bifurcates into the two posterior cerebral arteries at the level of the midbrain, and the branches of the posterior cerebral arteries include the perforator supplying the rostral midbrain, where the vertical gaze center is located. The posterior communicating artery arises from the posterior cerebral artery and connects the posterior cerebral artery or the posterior circulation with the internal carotid artery of the anterior circulation. The posterior choroidal artery supplies the lateral geniculate nucleus, and rarely there can be an artery of Percheron, which is a large single artery arising from one of the posterior cerebral arteries and supplying both sides of the midbrain. The posterior cerebral artery then continues as the calcarine artery, supplying most of the primary visual cortex except the occipital tip. So the posterior cerebral artery of the posterior circulation supplies the area of the primary visual cortex dedicated to the peripheral visual field mostly. Then we have the venous drainage of the visual pathway, and the venous drainage can be divided into the venous drainage of globe and orbit and the venous drainage of the intracranial visual pathway. The main drainage pathway of the globe and the orbit is the superior ophthalmic vein, and this lies superomedially in the anterior orbit. The superior ophthalmic vein then crosses over lateral before exiting the orbit through the superior orbital fissure outside the annulus of Zinn and drains into the cavernous sinus. And the superior ophthalmic vein receives the following tributaries: the central retinal vein receiving drainage from the retina, the vortex veins receiving drainage from the choroid, the episcleral venous plexus receiving drainage from the anterior segment, and the Schlemm's canal. So the superior ophthalmic vein drains the entire globe, the retina and the choroid in the posterior segment, as well as the anterior segment and the Schlemm's canal. And between these three territories there are extensive collaterals which can give rise to enlarged shunt vessels when one of these territories is obstructed. The superior ophthalmic vein also receives drainage from orbital structures and connects anteriorly with the angular vein and inferiorly with the infraorbital vein and the pterygoid plexus. The inferior ophthalmic vein drains the inferior part of the orbit and connects variably with the cavernous sinus directly or through the superior ophthalmic vein, and also connects with the pterygoid plexus through the inferior orbital fissure. Coming to the territory of the external jugular vein, at the medial portion of the eyelids, the superior ophthalmic vein communicates with the angular vein, and the angular vein continues as the facial vein, and the facial vein travels inferiorly and laterally to become the external jugular vein, which joins the subclavian vein. Coming to the venous drainage of the intracranial contents, the cerebral cortex drains into the superior and the inferior sagittal sinuses, which lie in the falx cerebri in the midline. The superior sagittal sinus helps in CSF drainage through the arachnoid villi and the Pacchionian granules. The midbrain and the diencephalon drain via the vein of Galen, and the vein of Galen and the inferior sagittal sinus drain into the straight sinus, which runs posteriorly in the junction of the falx cerebri and the tentorium cerebelli. The superior sagittal sinus and the straight sinus then drain into the confluence of sinuses, where tentorium cerebelli, falx cerebri and occipital bole meet. Two transverse sinuses travel horizontally forwards from the confluence along the attachment of the tentorium cerebelli to the skull. On reaching the petrous temporal bone, the transverse sinus turns downwards as sigmoid sinus, which drains into the internal jugular vein through the jugular bulb. Anteriorly, the cavernous sinus receives drainage from the superior ophthalmic vein. It also receives some drainage from the anterior cerebral cortex. The two cavernous sinus are connected to each other through a network of veins through the sella and over the clevus. The cavernous sinus drains primarily inferiorly through the inferior petrosal sinus, which runs through the Dorellos canal along with the sixth cranial nerve to drain in the jugular bulb. The rest of the drainage from the cavernous sinus occurs through the superior petrosal sinus along the petrous apex, which drains into the junction of the transverse and the sigmoid sinus. Small branches may pass through the foramen rotundum and foramen ovale to connect with the external jugular system. Thank you for listening.